Welcome, everybody, to this fun pharmacology talk. We are going to be describing today one type of medication that you see listed on here first. It's diuretics. Everybody in physiology and pharmacology and all of the health sciences just cannot get enough of renal physiology. So, luckily for all of us, I'm in that camp too, and I hope you are. We are going to be discussing diuretics and the way that they work to lower blood pressure therapeutically by their action in the kidneys. So, come along. So, diuretics can be used for a variety of things, but typically, when individuals think of diuretics, they think of water. They think of their water pills. That's your H2O. You can see how good my handwriting is. Diuresis is a scientific term for water loss. So, diuretics are used in hypertension treatment, so treating high blood pressure by promoting diuresis, so promoting water loss. And this is going to reduce the amount of plasma volume inside of vessels, so there will be less stretch placed upon the vessels themselves, which will lower blood pressure. We'll see that we can also use diuretics for other types of edematous states, so just edema in general, but ascites, cerebral edema in some cases, but their mechanism of action is going to be to promote diuresis. So we call them diuretics. We are promoting water loss, and this activity is renal. It is going to be within the kidney. So this is a type of treatment on the heart that is not going to affect anything directly cardiovascular in nature. It instead is going to have its effects in the renal tubule. Speaking of the renal tubule, here we have one. Not only do we have a renal tubule, we have a collecting duct too, which makes this a nephron, which is the functional unit of the kidney. And if you remember from your renal physiology, the job of the nephron is to take the filtrate, so all of the things that have been filtered out of the blood via the glomerulus, that complicated little bundle of fenestrated capillaries. So those fenestrations are holes, and anything that makes it through those holes from the high pressure glomerulus into the first part of the renal tubule, known as Bowman's capsule, is now considered the filtrate. So anything here that's going to get inside this renal tubule will be destined to eventually be excreted in the urine. When things initially enter this tubule, they have entered mainly because of their size. If they make it through the holes in those capillaries, they make it into Bowman's capsule. And that's going to include things like our acids, our bases, our electrolytes, water, things that we probably want to keep in the body and not just excrete through the urine. So as this filtrate moves throughout the renal tubule, we take back through different processes that we collectively call reabsorptive processes, things that we want to retain in the body. And what you see here in this picture, first, you don't look at anything in green, like thiazides there, that's in green. So let's not look at that. First, let's orient ourselves to the other colors in here. Whenever you see an arrow in red, that means it's moving into the bloodstream. So when you are looking at these various pieces of the renal tubule, you'll see sodium going to the blood. You'll see potassium being exchanged for that. One of the processes that we see used in reabsorption, aside from just simple diffusion, which is high to low concentration, is also active transport. And active transport occurs when there's ATP used to generate enough power to run a pump. And these pumps can either move things in one direction, they can move things in opposite directions. they can move more than one thing in those directions too. And the way that diuretics work is by taking advantage of these pumps, these ATP-run pumps used for active transport, so that we can transport things that we want to retain back into the bloodstream. It utilizes them and then targets them, and almost all of these medications will work to turn off one of these transport systems. So the red, as I noted in this picture, anything that is written in red is destined for the bloodstream. In this picture also, you'll see green writing. Those are the names of the medications. And then you see the associated mechanism of action and area of action. The first class of medications we'll talk about are carbonic anhydrase inhibitors. Carbonic anhydrase is an enzyme that is present in the proximal convoluted tubule, and it helps to reversibly convert things like bicarbonate and water and CO2 into each other and back again, so that we can have usable products for the bloodstream and for the body. So carbonic anhydrase inhibitors inhibit an enzyme up in the proximal convoluted tubule that the end result will be blocking this movement of things like sodium and bicarbonate into the blood. Rather, we're going to turn this off. That's why there's a little negative sign here. We'll be turning off this mechanism. And if we don't retain water, remember, where sodium goes, water follows. If we block this retention of sodium, then we will not bring water along with it. There will be less water than in the plasma, and then less volume in the vessels. Less volume equals less pressure, less stretch, so that will lower the blood pressure. The next thing written in green here are loop diuretics. Loop diuretics are named as such because they work in the anatomic loop of Henle. The loop of Henle has thin and thick ascending and descending limb segments, and the area of activity of this class of diuretics is in this thick ascending loop. That's what TAL stands for here, the thick ascending loop. In this area, there is a really, really big symporter. This symporter moves normally into the bloodstream sodium, potassium, and 2 chlorides. And you can see those things moving in one direction. So the sodium would be moved into the blood. Again, where sodium goes, water follows. And all of these diuretics are working to increase water loss, diuresis. So instead of retaining this sodium, loop diuretics turn off this pump so that we don't get sodium moving into the blood. We don't retain the sodium. We then keep the sodium in the tubule so that it will be destined for excretion. And because sodium and water travel together, when the sodium gets excreted, so does the water. So the blood pressure will go down. All right, so loop diuretics, they work in the loop of Henle. They work on that really big symporter, the sodium potassium 2 chloride symporter. They're the strongest diuretic class. They're the most common diuretic class. Next, we have thiazide and thiazide-like diuretics, which work up in the early distal convoluted tubule on a relatively simple transport system that moves sodium and chloride into the bloodstream. Thiazide and thiazide-like diuretics inhibit this transport of sodium and chloride into the blood, letting sodium be retained in the nephron so that it will be excreted out along with the water that would travel with it, and then lower the plasma volume, lower the blood pressure. So thiazide-like diuretics, they are going to alter sodium and chloride transport and cause and promote excretion of sodium and then water. Finally, we have potassium-sparing diuretics. They're the only class of diuretics that are actually going to lead to the retention of potassium. Almost all other medications are going to have that side effect of a loss of potassium. Not these ones, so much so that they named them potassium-sparing diuretics. And potassium-sparing diuretics, they work up in this early cortical collecting duct, late distal convoluted tubule area on a antiporter, meaning that it moves two things in opposite directions from one another, that normally trades sodium for potassium and hydrogen ion. And our hydrogen ion is our main acid in the blood and the body. Aldosterone normally works to turn this pump on, and aldosterone is released when you are dehydrated, when you are dying, when the blood pressure is falling really low. Aldosterone promotes the retention of sodium, and then sodium brings water along with it so that the blood becomes engorged with water and the stretch of the vessels goes up, the pressure goes up, and blood pressure is restored. Potassium-sparing diuretics turn off activity of this large antiporter so that we don't get the moving of sodium into the blood. It is retained in the tubule. It is excreted out. Water is excreted out. And then, because of the transport system moving things in opposite directions, because we're excreting out the sodium, we're not keeping it like we normally would, we are then going to eventually have the retaining then of potassium. So they are called potassium-sparing diuretics. So we'll get into more specifics in just a second, but those are your classes: carbonic anhydrase, loop, thiazide and thiazide-like, and potassium-sparing. Here's a great image bringing us to the next part of this talk, which is going into more detail of these specific medications and building on their location and mechanism of action. You'll also see that we've added one other class of diuretics. You see mannitol labeled there. Mannitol belongs to a class of osmotic diuretics, and they don't really have any other activity aside from the osmotic gradient. And the osmotic gradient is the pressure necessary to force or promote the movement of water. So we'll talk about that in a second. But we've got our 5 now different types of diuretics. We've got our carbonic anhydrase inhibitors up in the PCT. We've got our osmotic diuretics, which are also going to work along in the PCT area. We've got our really common loop diuretics over in the loop of Henle on that big co-transporter. And we have our thiazide and thiazide-like diuretics over in the distal convoluted tubule. And then we've got our late distal convoluted tubule collecting duct medications, our potassium-sparing diuretics. You have all of them labeled here. If you take a screenshot of this, make sure you note that Nature Reviews Cardiology provided this image. So here we are, carbonic anhydrase inhibitors. This class of medication is going to inhibit the activity of an enzyme referred to as carbonic anhydrase. This enzyme is present on the brush border side of the cells of the proximal convoluted tubule. Where it says tubular lumen over here, that is indicating that that would be inside of the renal tubule, whereas this rectangle here represents an individual cell of the renal tubule itself, which would lay right up against the peritubular capillaries, which would be over to the right. The space between the capillary and the tubule itself is referred to as the interstitial space. So carbonic anhydrase here in this tubule cell, again, sits along the brush border side, and its job is to convert reversibly these bicarbonate ions. When they come into contact with the brush border, they will initially combine with a hydrogen ion. So carbonic anhydrase here in the brush border, this is referred to as type 4 carbonic anhydrase. What that works to do is split this bicarbonate and hydrogen ion that got together to form carbonic acid. We see this labeled down here in full. Splits it into water and CO2. Water and CO2 are small. They do not need specialized transporters. They can happily diffuse over the surface of the membrane. Once they enter the inside of the cell, they meet with carbonic anhydrase type 2, which is going to reverse this reaction. So it takes the water and CO2, and it moves it from carbonic anhydrase back into its component parts of hydrogen and bicarbonate. There are two exchangers located on this cell. There's a hydrogen sodium exchanger on the luminal side, and then you see we have a bicarbonate chloride exchanger on the basolateral side. So in red, I have circled our sodium and our bicarbonate. The way that this system would normally work is that while carbonic anhydrase is putting these things together and taking them apart, what we are doing is converting substances to eventually get sodium and bicarbonate moving back and reabsorbed into the bloodstream. So if we do not have carbonic acid there to initially interfere with this reaction where the bicarbonate and the hydrogen got together, then we don't have it made into water and CO2 and able to diffuse into the cell. So we essentially arrest it at one stop. So like all of the other diuretic medications, one of the main things it's going to do is prevent the reabsorption of sodium and instead allow the sodium to remain inside of the tubule so that it can be incorporated into the urine. If sodium is incorporated into the urine, the water is going to follow the sodium. So we get the promotion of water excretion, also called diuresis. So it has that in common with all of the diuretic types of medications. One thing about these drugs is that it will target all types of carbonic anhydrase. We talked about type 4 and type 2. A little note that carbonic anhydrase is also located up in the eyeball, which means we can also utilize these medications to treat things like glaucoma, where we want to get the loss of fluid in a high pressure situation. So you'll see with these prototypical medications, acetazolamide, the first medication that's listed, is the typical one that acts upon the kidneys and is used to treat hypertension and other edematous states. In the eye, brinzolamide and dorzolamide are two medications which are incorporated into an eye drop preparation for topical types of administration through a fluid preparation to treat glaucoma. So acetazolamide is used orally to treat hypertension and other types of edematous states. The other place you can find carbonic anhydrase besides the eyeball is also within the choroid plexus, which is an area inside of the ventricular area of the brain that is responsible for the manufacturing of cerebrospinal fluid. So there are different types of cerebral edema where we end up getting the leakage of fluid into the brain, and we might want to inhibit the production of cerebrospinal fluid and then drive down intracranial pressure. One of these types is mountain sickness, and that's when you ascend a mountain and go through air pressure changes, atmospheric pressure changes, a little bit too quickly, and that can mess up the pressure gradient with inside of the meninges. So all of these medications, again, they're going to inhibit activity of carbonic anhydrase, which is responsible for this reversible reaction. It is located in the renal tubules, also in the eyes, the ventricles, and all types of edematous states, and then also anything that would cause CSF leakage or increase pressure inside of the eyes can be used. Next, we have our one weird osmotic diuretic. So this is not going to have activity at a specific transporter. Instead, it is going to work by driving up the osmotic gradient, increasing the osmotic pressure, so it will force water to move, essentially. Mannitol is our prototypical osmotic diuretic, and as indicated by its name, it is going to force the movement of water. It is given IV, so mannitol as a substance, like M for mannitol, it is a heavy, waxy type of substance that will be incorporated into the filtrate. So once it gets to the kidneys, it'll be secreted into the proximal convoluted tubule and station itself then inside of the lumen. So here on the luminal side of these tubule cells, we see the mannitol. And again, mannitol is something that attracts water. We are going to have an altered osmotic gradient. As mannitol itself is not very easily trafficked across membranes, so the mannitol cannot get into the tubule cells itself. It is going to stay on the luminal side. Water, remember, through osmosis likes to move to areas where there is high solute concentration. It moves via the osmotic gradient. When water then is forced to move through osmosis, it will come from whatever compartment it's in, the tubule cells itself, from the extracellular compartments, doesn't matter. So we'll have the mass movement of water from compartments through cells to make it to the lumen. This is really just going to add water as a bulk to the filtrate. That's going to cause the activity of the kidneys to pick up quite a bit. There's going to be all this water drawn into the tubule. Whenever activity goes up in any area of the body, physiologically, what happens is that blood flow increases to that area as well. So we'll have increased diuresis through this osmotic process caused by mannitol, and then we'll have increased activity at the level of the tubule because it has more to do, so we're going to need more blood flow. That also means, though, that you can use this medication specifically to increase renal blood flow in any type of ischemia. If there was ischemia to the kidneys, and again, any kind of abnormality, your body would work through this renin-angiotensin-aldosterone system to raise the blood pressure. Mannitol can reverse that ischemia and promote diuresis at the same time. So you're going to get a massive loss of water. Remember that the water that's going into the inside of the nephron that's going to become the filtrate can come from cells itself. So you can see reduced intracellular volume. So cells can shrink because we are changing the composition of its environment. Also, when we lose a whole big amount of water at one time, we are not altering any kind of electrolyte balance. We're just losing water in this case, which means that something like hypernatremia, which is too much sodium in the blood, is a risk. And in some cases, we call this relative hypernatremia, meaning that you're not truly saddled with a hypernatremic state where there's too much sodium for a pathologic reason. In this case, we've just messed up the ratio of water to sodium. So we call it relative in that it is something that can be restored by the maintenance of fluid administration. So again, diuresis without water loss. So in some cases, it's called an aquaretic diuretic with no alteration to transporters that move various electrolytes or acids or bases. So we're just getting water loss. And this can not only be used for our prototypical hypertension and edema, this can also lessen any kind of pressure pathology that is indicated by too much fluid being present. So it can decrease intraocular pressure. It can decrease intracranial pressure because it causes so much increased activity and then water loss through a rush of water moving through the tubule. It can also be used to kind of flush out remnants of anything that may have been broken down too quickly by the kidneys. So you can see this in rhabdomyolysis, where there's a massive breakdown of myoglobulin. And you can also see this with the massive breakdown of erythrocytes and different types of hemolytic states. So osmotic diuretics given IV promote water loss, diuresis, through just the osmotic gradient change by introducing mannitol to the system. Okay, now we are on to another class of diuretics, the thiazide type diuretics. Now, just to orient you to a little bit of the structural pharmacology here, there's thiazides and thiazide-like diuretics. Thiazide diuretics are easy to spot because they end in thiazide, chlorothiazide, and hydrochlorothiazide. Structurally, these medications are derivatives of benzothiazide, whereas thiazide-like diuretics, they look like and act like thiazide diuretics. However, they are derivatives of the sulfonamide type class substances, which, if you see this in here, do keep in mind that some individuals do have an allergy to sulfa derivatives. So thiazide-like diuretics may instigate a hypersensitivity in those individuals. So your thiazide-like diuretics include HCTZ, chlorthalidone, and dapamide, and metolazone. So structurally, they are different, which is important because of the allergies associated with them. So these types of medications, again, they are going to work up in the distal convoluted tubule, specifically in the earlier arm of it. And if you think about the physiology of this part of the renal tubule, you might remember that this is an area that is really important in secretion. The distal convoluted tubule has a really large role in secretion, where again, something that is not desired to be kept in the bloodstream, in the body, can be put right into the renal tubule without going through the filtration and ultrafiltration process. So there's some secretion transport systems that are already located within this area of the renal tubule. The secretory transporter by which thiazide diuretics enter the DCT is a uric acid transporter. One thing to keep in mind about these medications is that this drug class thereby is competitive with uric acid for movement through that transporter into the tubule. So keep that in mind for when you are picking a drug to give somebody. We might have the case where we have too much uric acid then remaining in the bloodstream and not moving out for excretion. If you remember your pathology, when you have too much uric acid in the blood, hyperuricemia can lead to gout. So this would be contraindicated in gout because it is competitive with uric acid. But once these substances do move through that uric acid transporter into the DCT, they have their main activity inside of these tubule cells. And as I pointed out earlier on in the talk, we are dealing mainly with a symporter that's moving sodium and chloride first into the cell itself, and then eventually sodium will move out into the interstitial space and then into the bloodstream for retention. You can also see here that where sodium goes, water follows. It's going to drag that water along with it, which will help to maintain the blood pressure. The other things that are important, though, that are also occurring in the cells, that we have an open calcium channel, so calcium's traveling to inside of the cell, so it can engage in different physiologic functions and then just maintain homeostasis inside of the cell. And that calcium also powers the sodium-calcium exchanger, which is going to help maintain the potential, the resting potential essentially of the cell membrane. So the mechanism of action of these drugs is really just to block this symporter, this sodium chloride symporter, because remember, we don't want this to happen. People take these medications to lower their blood pressure. We don't want sodium and water into the blood. We would like these people to pee it out instead. So we can block this symporter to get the main effect of the sodium not moving into the blood. What this means, though, is because all of these things work together, these transporters and channels, when we do block activity of the sodium chloride transporter, we are going to prevent the movement of sodium outside of the cell because we're not bringing it inside of the cell. However, we're still going to be moving calcium into the cell. And then that's calcium is going to eventually move out. So we can have an increase in calcium inside of the cell and then also calcium in the blood. Also keep that in mind because it can cause, in some cases, high levels of calcium, which can lead to kidney stones and other calcification types of states. So the calcium is still important there, even though the sodium chloride transporter was the only thing that we're really targeting. Unfortunately, everything in your body works together and it doesn't really care if you just want to do one thing at a time. So these are relatively strong diuretics. They are first-line choices for hypertension and second-line choices for other types of edematous states. Thiazide-like diuretics, distal convoluted tubule, sodium chloride symporter. Next up, we have our loop diuretics, the most commonly used and the strongest type of diuretic. The most commonly used in hospital settings, especially IV, is furosemide, also sold as Lasix. Then we have bumetidine and torsemide, and those three are also sulfonamide derivatives. Do remember that we can have hypersensitivities occur with these types of medications. Ethacrynic acid, then, is a medication where we don't have to worry about the sulfa interaction because it's a derivative of phenoxycetic acid. All right, so diuretics promote diuresis, the loss of water. Water goes where sodium goes. So all of these medications are going to be in some way promoting the movement of sodium into the excretion pathway rather than into the bloodstream. So the site of activity of loop diuretics is within the loop of Henle on a specific transporter that is a giant co-transporter. It's a symporter, meaning that it moves multiple things in one direction. So this transporter normally moves sodium, potassium, and two chlorides into the cell. And the concentration of these things in and outside of the cell helps to power pumps on the other side, like the sodium-potassium pump that every cell has, chloride transporters, potassium transporters, and it also is going to affect the osmotic and then diffusion gradient with other substances that might take a paracellular route rather than having to go through any pump system. So you can see here calcium, magnesium, sodium. Those normally can move into the blood rather easily. However, with loop diuretics, we are going to alter the permeability and the movement of certain things so that we can promote or block their excretion. What you'll see is that loop diuretics in general, they do promote the loss of all of these things over here, calcium, magnesium, and sodium. So we can see them being used not only for things like hypertension, but also hypercalcemia. And I wrote it twice. I guess it was really important for me to say that. What I meant to say is hypermagnesium. In addition, for its utility in treating hypertension and edema and our hypercalcemia and hypermagnesia states, we will also see that other substances that enter through secretion the loop of Henle at this site are bromide, fluoride, and iodides, and altering activity and then concentration of various ions in this area will promote the excretion of those substances. This is a medication that carries a risk of causing a type of acidosis where there is also low potassium. Low potassium is always going to be a side effect of loop diuretics because we're shutting off this whole transporter, which also normally moves potassium into the bloodstream. So if we're turning that off, the potassium is going to go out in the urine along with the sodium. When we are excreting then the chloride along with our sodium and potassium, if we excrete too much chloride and don't match that up with the amount of bicarbonate there is in the body, then we can induce acidosis. So loop diuretics, they work in the loop of Henle. They are going to inhibit activity of this really big symporter, the sodium potassium 2-chloride symporter. So we already have tons of diuretics we can already use. Why do we need another class of diuretics, right? Come on. Well, remember that even though all we want to do with these medications is excrete sodium and then the water that goes along with the sodium that we're excreting to lower the blood pressure and lower water and pressure states in the body, we're often exchanging that sodium for potassium. So we end up getting low levels then of potassium. Low potassium, especially with loop diuretics, is a side effect. You can see that thiazide and thiazide-like diuretics do decrease that amount of hypokalemia that you would see otherwise with loop diuretics. But there's also this other type of diuretic, the potassium-sparing. And potassium-sparing have a relatively straightforward mechanism of action. In the distal convoluted tubule, there is a site where aldosterone normally works, and it is just a plain old sodium potassium antiporter. So it moves sodium in one direction and potassium in the other. Remember, aldosterone is your sodium sparing hormone. It is released when blood pressure is low and we don't want to get rid of sodium. We want to retain it and the water that it carries along with it by virtue of it being sodium, and it's going to raise the blood pressure. So we can take advantage of this system and say, well, if aldosterone does that, if it works here on this pathway to raise the blood pressure, then we can block that pathway and then decrease the blood pressure. And that is exactly what potassium-sparing diuretics do. So they work relatively well to lower blood pressure. They are not as strong as loop diuretics, but they do not have the hypokalemia side effect. In fact, these are the only type of diuretics that actually is going to cause increased potassium levels in the bloodstream. They are called potassium sparing for a reason. We end up excreting the sodium and then keeping the potassium, which means patients should keep an eye on any extra potassium that they're taking in. And definitely not supplement potassium because they're probably going to have just enough. Amiloride, triamterene, spironolactone, eplerenone, also sold as Inspra, are all types of potassium-sparing diuretics. They are taken orally, and they all work within the distal convoluted tubule early cortical collecting duct area on the sodium potassium pumps. So the side effect you might see here is hyperkalemia, really high potassium. But in your patients that cannot tolerate these low potassium states, potassium sparing are a great way to counteract that. One last thing to keep in mind about these medications, nothing in the body is simple. Aldosterone comes from the cortex of the adrenal glands, and some cells right by there also make an androgen, DHEAS. So there is some androgen activity associated with potassium-sparing hormones. You actually see spironolactone being used in various reproductive disorders. We'll talk more about that later. You can ask about it, and we cover that in some other lectures. I hope you enjoyed learning about diuretics to promote diuresis and lower the plasma volume and then pressure throughout the system. Thanks.